All right, welcome to this Medical Explainer. We've got a mission today to crack some high-yield orthopedic trauma cases. We aren't just here to memorize facts, though. We're going to break down the biological why behind every single answer so these clinical applications become second nature to you.
Okay, let's dive right into our clinical shift schedule for today. We're hitting 4 main areas: bone healing and non-unions, pediatric growth plate injuries, high-energy trauma and polytrauma, and finally, biomechanics and nerve injuries. Let's get to it.
Section 1. Bone healing and non-unions.
All right, first case. Picture a 10-year-old kid rolling into the surgical emergency department after a bad fall. X-rays show a displaced femur shaft fracture, meaning there's a distinct gap between the broken bone ends. Knowing this fracture is going to heal by an indirect mechanism, the question is, soft callus formation follows which of these phases? Is it mineralization, lamellar bone formation, remodeling, hematoma formation, or hematoma formation with vascularization? Think about it for a second and lock in your diagnosis.
Got it? Okay, the correct answer is E, hematoma formation with vascularization. This right here is an absolute critical exam pearl. You see, indirect or secondary bone healing kicks in when a fracture is fixed with relative stability. That allows for just enough controlled micromotion to stimulate a callus.
Let's walk through exactly how this happens chronologically. Right after the trauma, torn vessels bleed out and create a fracture hematoma. Within just a few days, angiogenesis kicks in. That local vascularization turns the clot into functional granulation tissue. Okay, only then do mesenchymal cells migrate in to form that soft fibrocartilaginous callus, which eventually hardens into a bony callus and undergoes cortical remodeling. The real key takeaway here? It's the mechanical strain rule. The local interfragmentary strain literally dictates what the cells turn into at every single step. A moderate strain of about 2 to 10% is the sweet spot that stimulates chondrocytes to build that soft callus.
Moving right along, let's see how this builds. We have a 44-year-old diabetic male patient with a tibial shaft fracture. It's been 7 months, and follow-up X-rays show a gap between the bone ends with absolutely zero callus formation. None. So what is the best management here? A cast, plate fixation, bone graft, external fixator, or intramedullary nailing? Look closely at those clues. 7 months. Diabetic patient and zero callus.
Okay, the correct answer is C, bone graft. What we're looking at is an atrophic non-union. Now, what's really interesting about this breakdown is how the distal third of the tibia is totally notorious for this, mostly because it relies on a really weak endosteal blood supply. An atrophic non-union isn't just a mechanical issue, it's a fundamental biological failure. The bone ends are metabolically dead, which is only made worse by his systemic diabetes. You can't just slap a plate on this and call it a day. Atrophic non-unions absolutely require surgical debridement down to fresh, bleeding bone margins, followed by an osteoinductive bone graft along with internal fixation. This perfectly contrasts with a hypertrophic non-union, right? That one is a mechanical failure with tons of exuberant callus that just needs rigid stabilization, no graft required.
Section 2. Pediatric growth plate injuries. Here's a quick structural mapping question to test your baseline pediatric trauma knowledge. In the Salter-Harris classification, a fracture running through the growth plate with extension into the epiphysis is which type? Type 1, 2, 3, 4, or 5?
The answer is C, type 3. This is a classic intra-articular fracture pattern where the break runs horizontally through the weak hypertrophic zone of the physis, and then it just shoots vertically right into the joint space. Let's unpack the famous Salter mnemonic cleanly so it really sticks with you. Introduced by a couple of Canadian surgeons back in 1963, this classification was a real game changer for pediatric orthopedics. Okay, so S is type 1, slipped right along the physes. A is type 2, above into the metaphysis. L is type 3, lower into the epiphysis. T is type 4, through both. And R is type V, ruined or crushed. You really want to pay special attention to type 2. Epidemiologically speaking, it's the most common by far, making up about 75% of cases. The good news? It carries an excellent prognosis for normal bone growth because the fracture entirely spares the epineural blood supply and the articular cartilage.
But what happens when things go wrong? Let's take a 10-year-old with a type 4 lateral condyle fracture. This break crosses the joint space, the physis, and the metaphysis. If this isn't managed perfectly, it leads to what we call physial bridge pathophysiology. The bone literally heals across the growth plate line, cross-linking it. This totally stops normal bone lengthening and causes this asymmetric growth arrest, leaving the kid with severe angular deformities, like a varus or valgus knee. And that, my friends, is exactly why these specific patterns demand precise,
anatomic reduction, and really stable fixation.
Section 3. High-energy trauma and polytrauma. All right, let's step into the trauma bay for this intense, multi-system scenario. You've got a 40-year-old polytrauma patient from a car crash. Pressure is tanking at 80 millimeters of mercury. He's got a subdural hematoma, intra-abdominal fluid on his fast exam, and a comminuted supracondylar femur fracture. He gets rushed to the OR. The abdominal bleeding is stopped. The brain is decompressed. So what is the treatment for that femur fracture right now? A cast, Steinman pin insertion and traction, ORIF, knee aspiration, or just IV antibiotics?
The life-saving answer here is B, Steinman pin insertion and traction. Listen, in a patient with hemorrhagic shock who is acutely acidotic and hypothermic, prolonged internal fixation is strictly, absolutely contraindicated. Let's contrast damage control orthopedics with definitive fixation. The overarching rule in the trauma bay is brutally simple. What kills first is treated first. You secure the systemic circulation and stop the brain from herniating. For the bones, you use damage control. A rapid bedside Steinman pin insertion for skeletal traction stabilizes the limb, cuts down the muscle spasm, and controls the local bleeding without putting an already unstable patient through complex, prolonged surgery. You defer the definitive fixation until their physiology is totally stabilized in the ICU.
Okay, here's another high-energy trauma situation. A 44-year-old man presents with a Gustilo-Anderson type 3A open tibia fracture after a brutal highway crash. We're talking extensive soft tissue damage, but adequate coverage. What is the preferred method of stabilization? External fixator, plate and screws, bone graft, or a cast? The preferred method is A, external fixator. Placing permanent internal plates and screws directly into a highly contaminated, poorly vascularized wound? Yeah, that's a direct recipe for chronic osteomyelitis. Instead, the external fixator stabilizes the bone alignment by placing pins far away from the messy zone of injury, which completely protects the local blood supply. As the protocols highlight, this must be paired with thorough serial debridements and really aggressive IV antibiotics. We're talking a cephalosporin and an immunoglycoside, plus penicillin if there's heavy soil contamination.
Section 4. Biomechanics and nerve injuries. Here is a really great biomechanical puzzle regarding surgical indications. Which of these fractures following trauma is an absolute indication for open reduction in internal fixation, or ORIF? Is it a Colles fracture, a displaced patellar fracture, a closed fibular fracture, closed clavicular fracture, or a closed shaft of humerus fracture?
The correct answer is B, displaced patellar fracture. Why? Well, because this is a severe avulsion injury. The powerful quadriceps muscle group pulls the proximal bone fragment completely upward, causing a total disruption of the knee extensor mechanism. Just to put that into perspective, your quads can generate forces up to several times your entire body weight when jumping. So, without an intact connected patella, the patient literally cannot even perform a straight leg raise.
And this brilliantly illustrates the concept of tension band wiring. A simple closed reduction simply cannot overcome that constant, intense quadriceps pull. No way! You absolutely must use an open reduction with a figure-of-8 tension band wire anchored by K-wires. This genius construct takes those distracting, pulling muscle forces and actually converts them into stable compression right across the articular fracture line every single time the joint flexes. It's really elegant.
Let's rapidly break down one final exam pearl that perfectly links anatomy to clinical presentation. A fracture of the fibular neck is heavily associated with injury to the common peroneal nerve. Why? Because that nerve winds directly around the lateral aspect of the fibular neck. When this nerve gets bruised or lacerated, you completely knock out the deep peroneal branch. That paralyzes the anterior compartment muscles, leaving the patient totally unable to dorsiflex. This produces the classic foot drop gait, right alongside sensory loss on the lateral leg and the top, or dorsum, of the foot.
So, we've decoded the biology of non-unions, we've mapped out the serious risks of growth plate trauma, navigated multi-system damage control, and even outsmarted biomechanical pull forces. The question now is, how will you apply these precise principles of biological healing and damage control stabilization the very next time you step into the trauma bay? Really think about the why behind the clinical guidelines and let that biological understanding guide your hands. Thanks for hanging out and learning with us on this explainer today. Keep cracking those cases.